Good morning, everyone. How are you all? Good? Yeah, it's great to be here again. Always enjoy coming to this part of the country, and it feels a bit like an extended family here because there's always such a warm welcome, even though it's a grey day. Did some of you stay up for the Super Bowl? Few, yeah. Are you happy? No? That's the thing about sport, isn't it? You just never know what's going to happen. It keeps you on your toes. What a great privilege to be able to come together in person and get some energy around this issue. And we've heard about the toll of the problem, the scale of the problem. I hope you don't feel daunted because what we can do is amazing when we come together. So I'm going to talk to you a little bit about what change is needed and why it's needed, and maybe give you some ideas about where to start. And you've already started. You've done loads, and since I've been here last, I've heard about lots of things that you've been doing. I come here to speak to you with a humility. I hope that you don't feel I'm some kind of expert who's coming to say you've been doing things wrong and you've been getting things wrong. That is not my message at all. I want to tell you that for most of my working life, I actively helped people to develop preventable disease and to die young. And for that, I will always be eternally shameful. But grateful that I now saw the error of my ways and recognized that my work as a nurse, in which I was helping people to smoke, was completely on the wrong track and was, violating people's rights to life. And I think actually it wasn't just that I was involved in systemic failures at a grand scale, but it was also systemic violence because it was about us as healthcare professionals harming patients, helping them to develop preventable disease and to die young. And so what we need to do is to really look at ourselves in the mirror and to hold our hands up and to recognize the error of those ways and make sure that we start to change. And my learning came from some research that I did when I studied how much time I, as a nurse, and my colleagues alongside me were spending helping people to smoke. And so we looked at things like how much we were shopping for cigarettes for patients, escorting them to smoke, facilitating them to have leave. Do you do fresh air breaks here in the Northeast? I met a psychiatrist from the Northeast once, a very lovely man, but he was signing his patients up to have leave in the graveyard, which was just at the back of the hospital where he worked. Now, none of the patients were paying their respects to patients who were to people who were buried in the graveyard, but he was signing them up for leave so that they could go out to smoke in the graveyard. I mean, the whole idea is just like beyond belief, isn't it? But I think we were all doing that, trying to find ways to help people to smoke rather than to help them not to smoke. And what we could do if we could just flip that on its head and say, we are not going to help people to smoke. We're going to put all of our energy into helping them not to smoke. We could do amazing things. So I think that the rules, the routines, the patterns of behaviours that have been well established and ingrained in mental health services has contributed to the unequal outcomes that we've heard about from Joanna and from Rachel already, and I'm sure that you are very familiar with. And it is these practices and these policies that are directly responsible for people with mental illness dying young. And we have to take responsibility for that. And we have to accept that this is all avoidable, and it's a violation of people's human rights, the right to equal access to care and treatment. Now, we've heard about the scale of the problem and the fact that people with mental illness are dying so young. And I don't mind saying this to you again. I know Joanna has said it, Rachel has said it, and I'm going to say it again. And I make no apology for saying it again, because we have to keep that at the forefront of our minds and keep thinking about that as a non-acceptable situation. I wouldn't be standing here before you if I had serious mental illness. I'd be dead a few years now. And that's not fair, is it? You know, it's people with mental illness have brilliant capacities. They are talented. They are, people with dreams and ambitions, the same as you and I. And they can do amazing and wonderful things if we can allow them to flourish. Rachel's already used this slide. But what it shows is that if we carry on doing what we're doing now, then people with mental illness will be significantly left behind. So we have to start to think about tobacco dependence as an illness, a disease, a really serious disease that's not a lifestyle choice, not a bad habit, but a really powerful addiction. And treatments are available for this illness, for this disease, that up to now we haven't really afforded people with mental illness to access. There's a lot of shame associated with smoking that we have been feeding as well, and leading people to be embarrassed about their smoking and to be living their lives so they're ducking and diving and trying to sneak around and skulk around the back having their cigarettes. And we have to take that away. And we have to help our patients to understand that their struggle to stop smoking is due to the tenacity of this addiction. And that it's not a failing on their part. And make sure that we are embracing and reaching those people who, as Rachel was saying, are quite easy to find. They are hiding in plain sight, aren't they? We know where these people are. We don't have to look for them. And so we need to then make sure that we are really assertively treating this disease as we would any other life-threatening disease. So if somebody came into hospital with pneumonia, we wouldn't pussyfoot around. We'd get straight in there with antibiotics, and we wouldn't ask the person, would you like me to give you antibiotics for your pneumonia? We would say, this is what you need. I'm your doctor, I'm your nurse, I'm your healthcare professional, and this is what you need to get you better. So we must have this opt-out approach to tobacco dependence treatment, and make sure that it includes behaviour change support. And we know what behaviour change support techniques to use. And we've got to embed regular CO monitoring into our practice. I'm always talking about this because, if we had a diabetic patient, we would be regularly monitoring their blood sugar levels, or somebody with high blood pressure would be getting their blood pressure checked all the time. So why are we not regularly checking the carbon monoxide levels in our patients who smoke? And we just have to keep at it. When we work in mental health services, we're used to working with people who've got chronic illnesses like schizophrenia. We don't give up on treating their schizophrenia. We keep going again and again and again. And it can take about 20 times for somebody with a serious mental illness to successfully stop smoking. So we need some energy, enthusiasm, and ambition for these people to help them to stop smoking. So the contact with a mental health service should be a really great opportunity to reach these people. And when people come into contact with healthcare professionals, it should be a teachable moment for them. If they're coming into hospital, they're in a forced abstinence situation, they have a break from their usual routine, and we can give them intensive support at that time. And of course, access to the life-saving medications. And these effective long-term treatments can have an impact on those individuals' physical and mental health well-being and recovery, but also on their families' health and well-being, and of course a wider community as well, and the NHS. Now, you all know what the treatments are, and I won't go through them in great detail, but what I am concerned about is that I haven't yet come to speak to a group of people who work in mental health care settings who are providing routinely cytosine and varenicline to their patients. So I'm going to ask you, put your hands up if you've prescribed or you've administered varenicline or cytosine to one of your patients with mental illness. There's one person in the room. And you know what I'm going to say to you? It's not good enough. So the first thing you have to do when you leave here today is to go back and to see how can you change that. Varenicline and cytosine is if you, as a member of the general public, went to your doctor and you said, I'd like to stop smoking, you would leave that surgery or that practice or that appointment with a prescription for cytosine or varenicline if it was indicated for you, if there weren't any contraindications. That is most likely what would happen for you. And why is that not happening for people with mental illness? I think it is discrimination that's hardwired and baked into our system, and you're the people who have the power to change that. It's just not acceptable to me that there's life-saving treatment that's cheap as chips and we never give it to the people that need it most. What is going on? Why is that happening, and what is that about? Now, you know the answer to that, I know the answer to that, and let's do something about it. I want the Northeast to change that. You guys have always been leading the way. The work that Fresh have done, the media campaigns, you have been leading the way in this space for years and years and years, and everyone looks to you to see what to do next. And this is what I think you need to do next. You need to start making this treatment available. For a course of cytosine, I mean, it costs less than £70 to prescribe this tablet for 12 weeks treatment. That's for varenicline and a little bit less for the cytosine. It's the smallest amount of money you can spend to save someone's life. It really is. So let's do it. And I want to encourage you to please combine the treatments that are available for people with serious mental illness who smoke as well. Because we see that when we combine treatments, we get even better outcomes. So why not throw the kitchen sink at it? You know, I think it was Rachel that said people with mental illness, we don't have just more people with mental illness smoking, but they're smoking longer and they're smoking harder than everyone else. So throw the kitchen sink at it. Let's give them varenicline plus the NRT and see where that gets us. And then add in your magic, your behavioural support, add in the carbon monoxide monitoring, and then you will see that gap closing. Guaranteed. Let's do it. Now, I think when it comes to helping people to stop smoking, we have to rewind and to have a little think about what is it that makes people smoke. And the book that I always go back to is The Theory of Addiction. If you want to read and understand more about why people smoke, I always go back to this book, Robert West, the lead author. And he says that there are essentially 4 reasons why people smoke. That they have a need to smoke because they have a hunger for nicotine. We know nicotine is a powerful addiction. He also says that people who smoke, they have a positive evaluation of smoking. They think, well, I come from good stock in my family. My uncle smoked until he was well into his 90s, and, I'll be fine. Thanks very much, but I'll be okay. We've got different genes. We've got good genes in our family. So they think a bit differently about smoking. They have desire to smoke because often in their life they have fewer things that give them pleasure and enjoyment. And let's be honest, smoking does give a sense of pleasure and enjoyment. We can't deny that. So we need to understand the role that plays in helping people to continue to smoke. And then there's also the impulse to smoke because people are around others who are smoking, or they're in a place where they usually smoke, or where lots of smoking is going on. And that's what happens in mental health hospitals, isn't it? Because we get people coming into hospital who've stopped, and then they restart again because they're around people who are smoking. So our responsibility is to be looking at these 4 things and to be thinking about how can we smash that? You've got to be a disruptor here and break these routines and these practices and these cultures apart. Just rip them up to shreds, because what they've been doing is escalating the problem, creating spaces where people smoke and where that's encouraged and that's facilitated, rather than making it hard, putting a lot of obstacles between people who usually smoke and their cigarettes. So if we're to think about that first quadrant, the people's need to smoke, you've got to be hugely generous with your nicotine replacement therapy. You've got to preload people with their nicotine before they come into your smoke-free hospital. You've got to be prompt with giving them their nicotine replacement when they step through your door. First thing you do, T and NRT when people come into your mental health hospitals. There's no time to wait. You can't do your admission process and then ask them, do you smoke? You have to do it first. T and NRT. The way to welcome somebody into a smoke-free mental health hospital. And then you have to give a plentiful amount of nicotine replacement therapy. Nearly every patient I visit in mental health hospitals are undertreated with their nicotine replacement therapy because we just don't give them enough. Why are we making it so hard for our people with mental illness to stop smoking? Why are we restricting these nicotine replacement therapy products? Why can we not just be generous and kind and give them loads of it? Because they're used to using nicotine. They've probably been using it since they were a child, and they know how to manage their nicotine. We don't need to do that for them. We can give them lots of it. And then help them to practice using it so they can get the most out of it, and give it to them for a prolonged time. Please make sure they have it when they're going back home, in their TTO bag. Don't make the assumption that they're only using the nicotine replacement therapy because they were in your smoke-free hospital. Give it to them when they're going home, and keep giving it to them for extended periods so that they can prevent them from going back to smoking. And make sure that whatever you do is person-centered. And Joanna said that so beautifully. And in Rachel's diagram, we see the person who smokes is at the center of everything we do. So thinking about their individual needs. So they're my 6 Ps for addressing the need to smoke. And I think if we keep those in our minds, we won't go too far wrong. We've got to think about reshaping those positive evaluations of smoking that people have. And we can do that in lots of different ways and be creative about it and keep having conversations with people about how to do that. I don't think we get very far with just asking questions. I think we get really far by having conversations with people and listening to what people who smoke need from our services and how we can help them to change their evaluation of smoking. And make sure that we encourage our patients to use things like apps and all the new technology as well that can really help with those messaging. Make sure they've got that right. The other thing then is about addressing the desire to smoke. I think it was Joanna that said, we come from, the history of the culture in mental health services has been an idea that smoking is all they've got. I think that's what she said. Smoking is all they've got. Well, that's just not good enough, is it? How do we ensure that our mental health hospitals and services are places where health can flourish, not where it can flounder? These are a couple of pictures that I've taken from my own work. The first one is of Leon. He's doing some artwork, and he's using the old disposable vapes that he used and creating beautiful pieces of art with them. And then there's James on the outdoor gym. I installed outdoor gym in every single ward garden in the hospital where I worked, so that when people go out for fresh air, there's something for them to do in the garden rather than smoke. I mean, in the past, the gardens at the hospital, well, nothing grew there. The only thing that was there it was like Dog End City in every ward garden. But now there's things to do when you go outside. Flowers to water and vegetables to tend and exercise and hopscotch and things like that. Things that we can do together. And the last picture there is of the park run. I set up the first NHS park run in the hospital with a patient who smoked 20 cigarettes a day when I met him. And he said to me, when I asked him, what were your hobbies? What do you like to do? He said, nothing. Can't think of anything. He couldn't think of anything he liked to do until he told me about how he used to run. And he ran for the school, he ran for the county. And I said, well, let's run then, because when you told me about your running, your face lit up, and I want to see you running. And he said, how's that going to happen? I'm in a psychiatric intensive care unit, Mary. Are you mad? Who's the mad one here? So we downloaded the 5K app and we started to run together around the garden in the ward with the fence around us. And then later we went further outside the fence. And now we have park run in the hospital every Saturday morning at 9:00. Please come if you're ever in South London. It's just brilliant because it's a way of saying to people, you can do whatever you want to do. Doesn't matter if you've got schizophrenia. And finally, my last point here is that we have to remove all the cues to smoke. There is no room anymore in our modern mental health services for nurses storing cigarettes for patients and handing to them when they're going out the door. Because all you're saying to your patients is, I really don't care about what you do with your health and your well-being. You can just smoke, but can you make sure you do it outside the gate, please? Just kill yourself out there. Just don't do it inside here. Let's not do that anymore. We need to make it easy for people not to smoke when they're in hospital and hard for them to smoke. So I've talked to you about CO monitoring and how important that is. And when you come, hopefully you're going to come into my workshops this afternoon, I'm going to be talking to you about how to change the culture in our mental health services, how to start to pull apart those policies and procedures that have got in the way of people's health and well-being flourishing, how to really shore up your treatment pathways so that you're giving those life-saving treatments to people with mental illness. combination NRT, the varenicline and the cytosine for long-term treatment, and making sure you've got really good education and pathways, because our colleagues who have come into the caring profession who are helping people to smoke, they're not doing that because they're not good people. They just don't know what you know. So we can share what we know with them and help them through really good quality education and training. And make sure we've got good support for implementing our new policies and procedures. And of course, keep an eye on the data. The data is powerful, isn't it, to help us to keep driving the changes. So I think I'm going to stop there. And just encourage you to do a little bit of disruption when you go back to work, and have some conversations with people and start to think about how you can do things differently. Thank you very much.